I think this will answer most of the things that you're looking for. And if you need more, I'd be happy to answer any other questions. Just disclosures. I also like to disclose that I try and teach molecular imaging and therapy starting at a young age. This is my son and my daughter helping me teach a molecular imaging course when I was back in New York. And this is several years later as they're helping me teach a course now here in California. And if you start early, they can, as you can see, they can start picking out the important stuff real quick. So I'm real proud of them. All right, so this is an overview of imaging for patients with prostate cancer, and many of your team are likely to have had one or more of these imaging agents. Can you see my pointer, my little white arrow? If I'm pointing to certain things, you able to see that? Yeah. Okay. So I'm gonna start with the traditional stuff, the bone-seeking agents, like bone scans. That looks like this and was very useful before we had more targeted agents. Then things like choline and fluciclovine came about and were FDA approved because they had greater sensitivity for finding prostate cancer than the older agents. Today, the best imaging agent for prostate cancer are these PSMA agents, or prostate specific membrane antigen. And there are several that are FDA approved today and are available for standard of care use, as well as many, many clinical trials trying to advance the science on these agents. Okay? This is a little outline of how all of molecular imaging and therapy works. My cartoon. The cancer cell has a target on it, in this case, the PSMA molecule, and we design keys that bind to that target, like that key fitting into a lock. And those agents are linked to something that emits radiation. Now, when that radiation is a low-level radiation, you get imaging agents, like the PSMA-targeted imaging agents. If you swap out those radioisotopes that emit a small amount of radiation for something that emits a lot of radiation, these beta and alpha particles, now you have PSMA-targeted therapy agents.
Yeah, the ding dong.
Right? So this is just a little diagram of what that molecule is, that PSMA that sits in the cancer cell. And it's such a great target because normal cells express very little of it, and prostate cancer expresses 100-fold more of it. So it is a great target to be imaging and a great target to be looking at if you want to design therapy agents. So that's our target, this molecule called PSMA. And now these are the different keys that are around to hit that target for imaging. There are what we call the PSMA-11s. They're gallium labeled PSMA-11s. So if you've heard of Illuccix or Locamets, those are FDA approved agents that are based on this molecule. My personal favorite at this point in time is the Lantheus Polarify agent. And the one that's most recently approved is the Blue Earth Posluma agent. All three of these agents hit the PSMA target through very similar mechanisms and very similar areas of the molecule. And these are the only ones that are FDA approved to date. There are others that are in clinical trials that are similar to the ones that are FDA approved, and then some that are very different from the ones that are FDA approved. And I see that this field is going to just explode. If you think this is where it's going to end, that would be wrong. There are going to be a whole host of different PSMA-targeted imaging agents and therapy agents approved in the next several years. So these are the imaging agents that are FDA approved to date. And then for therapy, sorry, I don't have this is an imaging talk, but I'll expound now upon the therapy. For therapy, there's only one that is currently FDA approved, and that is called Pluvicto. And that again is very similar to these agents. The binding agent is very similar, but the radioisotope is something that emits a beta particle, which is very high energy, as opposed to these molecules that have something that emits very little radiation. And that Pluvicto molecule right now is the only FDA-approved agent, but there are many more in clinical trials and that are going to get FDA approval. And one of them is offered by a group called Point. And that agent will in the next few months be coming out in something what's called expanded access, which means able for patients to get it at many different medical centers even before it receives its FDA approval, which is expected next year. Okay? So there are multiple different FDA approved molecular imaging agents targeting PSMA. One therapy agent that's approved to date, and one that's going to be at least one that's going to get approved next year, and several more that are going to get approved in the next couple of years. So people ask me, of these different imaging agents, which one is the best? And well, there's no one direct right answer, and they all do a tremendous job as compared to anything that came before them. So if you have the opportunity to use any of these, it's of value. But there are differences based upon the radioisotope and the binding molecule that do make differences. For example, the energy of the radiation that is emitted makes a difference, because the higher the energy, like gallium, the longer the positron travels before, in the physics, it hits an electron and annihilates and produces photons that are imaged. So essentially, the higher the energy, the longer it travels, and thus the harder it is to localize exactly where that positron came from. So you can't localize the cancer cell as precisely. You get an image with lower resolution. And here's that comparison. Here's the gallium agent. Here's a fluorine-18 agent next to it. And you can see, like when we're looking at the physiologic structures like the lacrimal glands and the salivary glands, the F18 agents have a sharper image than the gallium agents. Does this make a difference clinically? There are only retrospective studies suggesting yes, but to me, if based on the physics that this is what's supposed to happen, and indeed does happen, I think the fluorine-18 agents, like the Lantheus agent and the Blue Earth agent that were just approved, give slightly higher resolution than the earlier gallium-68 agent. So if I have my choice, I try and use the fluorine agents when possible. But then again, I'm going to back up a slide. All of these are so far above anything that came before it that if you have the opportunity to use any of these rather than a bone scan or say a fluciclovine scan, I highly recommend any of these over what was previously utilized. And for patients with metastatic disease, if you have the opportunity to use a PSMA-targeted therapy, the therapies tend to have higher efficacy than chemotherapy and fewer side effects. So that's a win-win. Better efficacy percentages and lower side effects as compared to the chemotherapies that many patients take. So if I were to try and summarize the current state of molecular imaging and therapy, I'm going to go here. Let me just quickly say that that this field, the research in this field goes on at a huge rate. There are more advanced phase studies going on in PSMA-targeted imaging and therapy that I think anyone these days has time to keep track of. So many of these agents are going to be are going to reach FDA approval. They're all going to be successful, and they're all going to have very small differences between them. So I think they're all going to be effective. So then now again, if I'm saying what our state of the art, if you have the opportunity to use PSMA targeted imaging, it's the most sensitive way of detecting both disease at initial diagnosis and when there's potential biochemical recurrence. And as far as therapy, with Pluvicto, you can have opportunities to have an effective therapy after receiving chemotherapies. And with these trials that are currently available, there are ways of getting PSMA targeted therapy prior to chemotherapy. So if you want to avoid chemotherapy, look for an institution that is offering one of the clinical trials that will allow you to get PSMA targeted therapy before chemotherapy, right? And I think that is really the most important 2 points. For imaging, the PSMA targeted imaging agents are the most sensitive method of visualizing prostate cancer to date. And for therapy, the therapies provide a higher efficacy therapy with lower side effects than chemotherapy. And I hope that provides at least a framework for people to get a little bit of understanding about what PSMA is, what PSMA targeted imaging and therapy is, and what their advantages are. And I'm happy to take any questions.
Outstanding. Thank you very much, Doctor, for an exciting and very hopeful presentation about the state of theranostics. Bill wants to know, is there any hope of a change in the requirement to receive Pluvicto treatment in the United States? You think it's going to happen this year?
Oh, well, Pluvicto, possible. If we go back here to these clinical trials, the upfront PSMA trial and the PSMA-4 trial are using Pluvicto earlier in the evolution of prostate cancer disease. So right now it's only approved, FDA approved after chemotherapy. These 2 trials will try and get it approved prior to chemotherapy. This year, maybe not. Next year, certainly a possibility. I'm gonna go out thinking that all of these, like the PSMA-4, Splash, Eclipse, these trials probably won't come to the FDA for approval till next year. So if you're looking to get a PSMA targeted therapy prior to chemotherapy now, the best option is utilizing one of these clinical trials, PSMA-4, Splash, or Eclipse, that allows you to get the PSMA targeted therapy on a clinical trial before chemotherapy. Once the FDA approves one or more of these, then it will become, I'm sure, very standard for patients to receive PSMA targeted therapy prior to chemotherapy.
Outstanding. Thank you. Dr. Metzger wants to know, where does the alpha particle fit in?
So the alpha particle, I'm going to jump around, pardon me. If we go back to this little diagram of my chart, the Pluvicto agent uses a radioisotope called lutetium-177. And that is the one that's FDA approved. And then there are others that are currently in clinical trials. The Eclipse and the Splash trial also use lutetium-177, which is a beta emitting particle. There are other trials that are in earlier clinical phases, so not phase 3 yet, that use a radioisotope like actinium-225, which emits an alpha particle. Now, the advantage of alpha particles is that they're far more energetic than beta particles, so they can cause more damage and kill cancer cells more effectively, as well as alpha particles travel shorter distances than beta particles. So in theory, there should be smaller side effects from alpha than beta therapy because you're sparing more normal tissue. All of this needs to be proven in advanced clinical trials, which it has not yet been done. Also, if we took a look at this diagram of where PSMA goes normally, like physiologically, notice that all of these agents go to the salivary glands. So alpha agents, they hit the salivary glands real hard. And patients on the early clinical trials who have had alpha prostate therapies, they virtually all complain of very dry mouth. So this is a side effect of alpha therapy for PSMA, which may limit its widespread use depending upon what is the patient's tolerance for living the rest of their lives with very dry mouths, would make it difficult or to eat and sometimes unpleasant, right? You don't taste your food. You have to use water or saliva replacement in order to chew anything solid. That is not a side effect that many people say, yeah, I'll deal with that for the rest of my life. So while alpha therapies have some significant advantages, it still has a ways to go in clinical trials. And it is, if we look at the current phase 3 trials that are out there, these other agents are going to come to FDA approval far earlier than alpha agents. So alpha agents is farther in the future and still less proven than the beta agents that are available. I see some other hands.
Deb King wants to know, what do you see as the opportunity for someone to receive PSMA therapy after chemo? And I believe that's pronounced doxycycline, even when they are still hormone sensitive. It's
possible. Most people who are hormone sensitive are not, like, you get the doxycycline when you're castration resistant. It's possible, as you can see from the diagram, when you're castration sensitive, that means you're still able to be treated with hormonal therapies, and doxycycline can be used in the castration sensitive line. So there are clinical trials of patients who are castration sensitive to receive PSMA targeted therapy. To me, if the tumor expresses PSMA, then it is likely to be responsive to PSMA targeted therapy. These days, this is what we're calling we call basket trials, where it used to be you did a clinical trial, you only looked at one type of therapy for one type of tumor. And these days, it's not the tumor type that's as important as it is the molecule, the target. So we know that PSMA is really highly expressed in virtually all prostate cancers. So this is why it is first being used in prostate cancer. But there are other tumor types that are expressing PSMA, like some renal cancers. So I expect that this PSMA targeted therapy to be utilized as it becomes more generally used. It's going to be utilized in other tumor types as well, as long as you're expressing PSMA. So right now, it's being used mostly for metastatic castration-resistant prostate cancer. I think it's almost certain that we're going to be using it in metastatic castration-sensitive prostate cancer, and it's probably going to come to bear in tumors other than prostate cancer, as long as those tumors are found to express PSMA.
Excellent. What is meant by referring to limitations? URINE is what I have here from Bob Morris in New Jersey.
Hit me. INE.
Urine. Urine.
Oh.
Urine.
What,
So
referring to limitations.
In the limit,
Okay, Bob.
you mentioned a list of limitations, and you mentioned urine in that slide. And one of the
limitations. Can you please let me know where?
at the end, the last.
So for PSMA targeted imaging, if you don't mind, I'm going to show a case. Here we go. This case. Now I know we're not all radiologists on this call. So this is a case of a patient receiving a PSMA scan. And if we look, this is the stuff we expect to see: the lacrimal glands, the parotid glands, the liver, the spleen, the kidneys. And there are these dots here, that dot, this dot, that dot, that are suspicious for tumor, right? This is the bladder, right? So when we look at these axial images through here, here's that first dot that's over here. And if we look at the CT scan, that corresponds to the ureter as it goes up and down, or from head to toe. So this dot here is not cancer, it's urine within the ureter. All right. And then if we look on the other side, this one here, here's that dot, and it corresponds to a lymph node on the CT scan. So this is cancer in a lymph node. And this is why I say one of the limitations of these imaging studies is urine, because if you look at the images, urine can look just like a cancer. So this one is cancer over here, and this one over here turned out to be urine, and this one down here also happens to be urine. So if you're not a good reader, right, a good radiologist, you can make errors in which you call something cancer when it's actually just benign, it's just urine, or you can miss a cancer because you think it's just another focus of urine. So it takes someone who's skilled at both the PET as well as the CT to put these puzzle pieces together in order to give the optimal read on these studies, so that you don't overcall urine as cancer and you don't undercall cancer as urine. So I call this one of the big limitations. And when people are just learning how to read these studies, mistakes happen around the ureters and bladder because of this.
Okay. Should you go into the test kind of dehydrated, so there's less urine floating around?
That's a great question. I don't think you should do that. All right. There have been trials in which they have used a Lasix, something to push the urine out of you, so that there's less urine in the scan, and it hasn't made any difference on the interpretation. So don't dehydrate yourself. If anything, go into any nuclear medicine study well hydrated, so that you can flush the agent out of your body after the study is done.
Okay, thank you.
Thank you. Michael wants to know, is it likely that Pluvicto can be more successful if it's used before the Mets get too large and diverse?
That's a great question. This is the the question people come up to me and say, boy, when I have these huge tumors, versus if I use Pluvicto in patients with little tumors, people seem to do better when the tumors are small. And that isn't necessarily a function of the Pluvicto. That's a function of patients with lots of disease do worse than patients with a little disease. So it's kind of like the pre-existing state. If you have a lot of disease, you're unlikely, you are less likely to respond well to many things, not just, all right, Pluvicto. So Pluvicto can be valuable in patients with large volume disease as well as small volume disease. And it really comes down to whether the PSMA is available to bind, going back to my little cartoon, is the PSMA on those cancer cells, is that accessible to the Pluvicto so the Pluvicto can bind and cause its effect? And if the answer is yes, then it's going to work whether you have big tumors or little tumors. And just, it's unfortunate for us to say, but patients with lots of big tumors, those patients have, you know, a worse outcome than patients with smaller tumors to start.
Very good. Bill Power, do you have a list of hospitals offering trials in the U.S. before chemo?
So that goes to these. That goes to a list. A list I do not have. I'll let you know. I have the Eclipse trial running at the Hoag Family Cancer Institute. The Splash trial, although it's term running, accrual is filled. So you're not going to be able to find spaces on Splash because everyone has been recruited to Splash that's going to be recruited. It just, the results haven't been reported yet. And then there are other places. I think UCLA has PSMA-4. So I'm afraid I don't have a list of where everything is available. If you happen to be interested in a PSMA-targeted therapy trial prior to chemotherapy, I would be happy to discuss the Eclipse trial with you, which we have open at Hoag and have many successful patients enrolled on it.
Thank you. What percentage, hold on here, let me get this so I can read it. What percentage of PC does not express PSMA? What imaging can they use to detect and monitor cancers that don't express PSMA?
What a great question. That is a great question, because if we go back, if you don't express PSMA, none of these, if you don't express this target, then none of these PSMA targeted imaging and therapy agents will work, right? And the percentages depends upon, you know, what source you're using for your citation. But in general, the percentage is low, in the range of 1 to 5%. I find it to be closer to the 1% than the 5%, but some people say around 5%. So most people, when they have prostate cancer, it expresses PSMA. Now, what is perhaps more troublesome is this concept of heterogeneity, that in some patients, not all the tumors express PSMA the same. So if you can imagine, if you have a patient with metastatic prostate cancer and there are 20 different sites of disease, and 15 of them express lots of PSMA, but 5 of them don't. If I give them a PSMA targeted therapy, I might successfully treat the 15 that express PSMA, but the 5 that don't keep growing. So while most people who have prostate cancer express PSMA, you have to be wary of patients that have some lesions, you know, the patients that have multiple lesions and some of them don't express PSMA. That's higher than the absolute number of patients. Like if you do a scan, hey, I don't see your tumor at all. That's in the range of 1 to 5%. But there are patients that have this heterogeneous expression of PSMA, and then we're still learning, you know, what % of the lesions do you need to express PSMA for these therapies to be effective or not? I will say that there is a type of PSMA, a histology of prostate cancer called neuroendocrine differentiated prostate cancer. Those prostate cancers tend to express PSMA at much lower levels than other types of prostate cancer. So if your path report says neuroendocrine prostate cancer, don't be surprised if these PSMA targeted imaging and therapies don't work. But that is still a very small percentage of prostate cancer.
Aloysius wants to know, as long as we're talking about alpha and beta particles and more energized beta particles, is the radiation levels harmful?
Well, they're supposed to be harmful. They're supposed to be enough to kill cancer cells. So all radiation is harmful. It's a balance between benefit and risk, right? So I wouldn't give someone who doesn't have prostate cancer one of these agents because they would get the risk, but they would get no benefit. But for patients with metastatic prostate cancer that express PSMA, the risk, the benefit far outweighs the risks of the radiation. So yes, radiation can be harmful, but when the benefit outweighs the risk, and for most people with metastatic prostate cancer that expresses PSMA, the benefits far outweigh the risks, it's a very valuable treatment.
Okay. Bill, you have a question about the places around the world like the Zentrenic. Help me out with that, Bill.
I'm curious if we're doing any shared learning and information. I've had 2 Lu-177 treatments at the Zentral Link Clinic in Bad Berka, Germany. Never had chemo, never had radiation. Outstanding results. And I will say I was radioactive coming back into Dallas and set off the nuclear alarms and upset everybody. But besides that, it was pretty good.
Oh yeah, well, I mean, the community shares information around the world. So the community in Germany shares information with the rest of Europe, as well as the United States and South America and New Zealand and Australia, which are all sites of research for PSMA targeted imaging and therapy.
We just seem to be way behind the rest of the world, seeing how Europe has opened it all up, 20 more hospitals in Germany.
I wouldn't say that, okay? This is what I would say, right? Germany doesn't have an institution comparable to the FDA. And they have laws that allow a physician to prescribe anything that they want as long as they say it is a compassionate use for the patient. The United States is on the other end of the spectrum. We have an FDA. We have clinical trials. A physician can't give things to a patient unless it's FDA approved or it's on an FDA approved clinical trial. So there are benefits and drawbacks of each system. The benefits of being in Germany is you can get stuff immediately, right? So the stuff that works tends to be done in Germany quicker. The drawback of the system of Germany is that 9 out of 10 things that you try early don't work. So there's a whole bunch of things that are being used in Germany, not working or may even be harmful, that we don't ever use in the United States because we have higher levels of proof before we're allowed to use them in this country. So what tends to happen is a whole bunch of stuff is used early in a place like Germany or Israel, where they have these looser standards, and therefore they always get to say they did it first. But the trials, like for Pluvicto, the VISION trial was run in the United States. So the trial that actually proved, the phase 3 trial that actually proved that it worked, was done in the United States, and it only got FDA approval after it had that tremendous overwhelming evidence that yes, it works and the benefits are better than the risks. So in that case, Germany goes, hey, we've been doing this for a couple of years, and indeed they have. But then there's 9 other things that Germany did, and by the time you do the phase 3 clinical trial, it ends up, it doesn't work, or it never even got to a phase 3 clinical trial. And you don't hear about that, not those 9 things that harmed people you only hear about the one that they did first, and it turned out to be a winner, and was proven in a place like the United States.
Thank you. I have another question from let's see here. It looks like Michael wants to know, do all studies with Pluvicto notify Novartis about the details of the study and the results when completed, either good or bad?
Well, if you're using Pluvicto, Pluvicto is A, FDA approved for certain indications, and B, copyrighted. It's trademarked, right, by Novartis. So anyone that's, and it's under patent. So anyone that's using Pluvicto has to be working with Novartis. So the answer there is yes. Anyone working with Pluvicto has to be working with Novartis because it's their agent.
Okay.
Now, there are a whole bunch of other PSMA-targeted therapies. All right. So for example, if you're working with PSMA-INT, that doesn't go through Novartis. That's a different company. If you're working with PNT 2002, that's going through another company. And if you're working with like J591 and actinium J5, that's going through different companies. So Novartis has currently the only FDA-approved PSMA-targeted therapy. I see in the next couple of years, probably as early as next year, that changing, because other people are going to be bringing their agents up for that are in phase 3 trials for FDA approval. So right now, if you're doing it off of outside of a clinical trial, if you're doing it by standard of care, Novartis and Pluvicto is the only game in town.
Okay. If the tumors are smaller, can the amount of radiation be smaller?
That has not been proven. For patients who receive Pluvicto, they usually receive the same dose of medication, which has been determined based upon how much radiation can be given before you get intolerable side effects. And I kind of like that model. As long as you're not causing too much harm, you want to hit the tumor as hard as possible to drive it down as far as you can. Because we know with metastatic prostate cancer, no metastatic prostate cancer at this point in time is cured. So what you're doing is taking this level of tumor and driving it, diving it down as far as you can go. So even if you start with a small volume tumor, you want it to dive as far as possible so that it takes longer for that tumor to build up again, right? Because we know, unfortunately, with metastatic prostate cancer, you wait long enough, right? If you're not hit by a bus, eventually the tumor is coming back.
Larry Weaver, if you have neuroendocrine cancer with low PSMA expression, what imaging should you use to find the cancer for radiation treatment?
Great question. So to me, every prostate cancer deserves one chance of being PSMA avid, right? So go for it, even if it's a neuroendocrine tumor. If it comes out to be PSMA negative, all right, then you have to go back kind of a generation of imaging agents. And the next one is fluciclovine. So here's an example of a patient with metastatic prostate cancer who had increasing PSMA, so biochemical recurrence. And this is their PYLARIFY, their PSMA-targeted imaging study. It shows no tumor. But because the PSMA was pretty markedly elevated, people were pretty highly suspicious the tumor was there. So we backed up and said, what if this is one of those uncommon prostate cancers that doesn't have PSMA expression? So we did a fluciclovine, which is an oxymin study, and lo and behold, here are the multiple sites of prostate cancer that were found on the fluciclovine. that were not seen on the PSMA scan. So before PSMA targeted agents, fluciclovine would be the state of the art. So to me, the answer would be, if you're looking, get the PSMA targeted imaging study. That's the most sensitive agent to date. And if the PSMA is negative, if you're one of these few percent that doesn't express PSMA, you can use the fluciclovine scan, the oxymin scan, as your next layer of investigation. How about one more question, and then I fortunately have a patient waiting for me.
Okay. Pat wants to know, I have a catheter. Can I do a PSMA with that in?
Absolutely. We do patients PSMA imaging and therapy, patients with catheter, patients who wear diapers. I won't say no problem. It is a little bit of a problem. It requires more diligence, right? So for the imaging agent produces so little radiation that it doesn't matter if you're entirely incontinent and just wearing diapers all day, it won't make any difference whatsoever. For the therapy agents, the radiation is high enough that we don't want this radiation drying on your skin. There have been examples of patients getting radiation burns on their skin from that type of urine leakage. But we just tell patients to change the diapers every hour or two, the first day or two. Some people go 3. Take showers to wash the stuff off so it doesn't dry on your skin, and the patients do just fine. So having a catheter or having incontinence is not a reason why you cannot receive PSMA targeted therapy. We do it all the time. Hey,
Doctor,
gentlemen. Yeah,
thank you so much, Doctor.
I hope that was of use to people. If you have further questions, Neil, you got my email. Please feel free to forward them to me. And
okay.
I wish everyone the best with their future treatments. And please let me know how I can be of service.
Thank you, Gary. Thank you very much. Excellent talk. And we're sorry about
Absolutely outstanding.
All right. You have a great day.
Thank you.
Thank you, Doctor.
Bye-bye.